Good afternoon, everyone, and welcome to today's webinar, 2021 Public Health Law Conference Preview Webinar, Equitable COVID-19 Recovery. Brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on our website shortly after the conclusion of today's event. We strongly encourage attendee participation, so feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We'll be addressing them towards the end of today's event. Your moderator for today's webinar is Betsy Lawton. Betsy is a senior staff attorney at the Network's Northern Region office, where she provides legal technical assistance and builds connections in many areas of public health law. Before joining the Network, Betsy spent over a decade working to improve water quality as an attorney with the Midwest Environmental Advocates and the Minnesota Center for Environmental Advocacy. She'll be leading us through the rest of today's webinar. So Betsy, over to you.
Thanks, Charles. Hello, everyone. Happy to have you with us today. I'm going to just briefly introduce each of our presenters, and then I'll be back with you after the presentations to help facilitate the Q&A session. First, today, we're going to hear from Peter Jacobson. He is the co-director of the Network's Mid-States Region Office and Professor Emeritus of Health Law and Policy and Director at the Center for Law, Ethics, and Health at the University of Michigan School of Public Health, where he taught courses on health law, public health law, and public health policy. Then we'll hear from Jen Pyatt. She's a senior attorney with the Network for Public Health Law's Western Region. She also serves as a research scholar with the Center for Public Health Law and Policy at the Sandra Day O'Connor College of Law. She earned her JD at the Sandra Day O'Connor College of Law at Arizona State University in the spring of 2018. Then we will hear from Dr. April Shaw, who's a staff attorney at the Network's Northern Region office. She's interested in a variety of health equity issues as they relate to economic, gender, and racial disparities. She's particularly interested in thinking through how multiple inequities intersect to create systemic disparities. So with that brief introduction, I'll hand it over to you, Peter.
Sorry, having trouble getting my video back on. Charles, can you get this? There we go. Thank you. So, welcome everyone. It's a pleasure to be presenting today. The panel that I'll be on, along with Rob Gatter from St. Louis University and Lance Gable from Wayne State University, is really designed to talk about whether the public health officials have a duty to take politically unpopular stands. When we started this work, it was largely around the tragedy of the Flint water crisis. And we were going in one direction. But one of the things we've learned from COVID, among many other things, is just how difficult public health officials have in making the right decisions in the midst of rapidly evolving public health crises. And if this sounds familiar from Flint, it was heightened during the COVID-19 process, pandemic. And what we want to do with this panel is try to understand the duty to speak out in both contexts and how COVID-19 might change the question of accountability from the kind of accountability measures we've seen in the Flint water crisis. What we've seen in both examples is that politics can overwhelm public health decisions. So the question is whether public health officials should oppose political decisions that threaten the community's health. And if so, how should the law account for this responsibility? What are the political and personal consequences for opposing political decisions? And I think it doesn't take a lot of imagination to understand that COVID-19 has presented major threats to public health practitioners. Pardon me. So the first presentation will be fairly general in discussing what it means to hold out for a public health hero. Should we expect, as a community, as a populace, that public health officials will take a stand? In Flint, as I'll get back to in a minute, it was about sounding the alarm over the lead in the water and then the Legionella outbreak. In COVID-19, it's much more complex in the sense that initially not all elected officials were willing to issue strong public health orders. So the question is whether our expectations are reasonable or unreasonable, logical or illogical. They're reasonable in the sense that we want our public health officials to really safeguard the community's health over competing interests. At the same time, it strikes me as being unreasonable in the sense that COVID-19 suggests the difficulty of balancing the competing interests with protecting the public's health. Same thing on logical and illogical. It's not illogical on one level to think that our public health officials should be more aggressive in protecting the community. On the other hand, they have families, they have jobs, and not everyone is capable and willing to put their careers on the line to oppose political decisions. And for another, they are not the elected officials. And there are times when it's not appropriate for appointees to oppose. One other way of thinking about it is, should one resign? If one thinks the politicians are in error and harming the public's health, along with sounding the alarm, should one resign? In most states, the legal duty is expressed in the state public health codes, and I'll talk more about that later. But more importantly, there's a professional loyalty to public health, a professional loyalty to the community, and in some cases, a commitment to speak truth to power. And I think that's really the key. Under what circumstances should a public health official be willing to speak truth to power regardless of the consequences, to set aside your professional self-interest in order to represent the community's interest during, let's say, a fiscal crisis, or when political decisions would threaten the public's health? What we've seen in COVID-19 is incredible public resistance to some of the orders, accompanied with threats to the health and safety of our public health practitioners. It seems to me that we can think about this as a minimal job requirement. At the same time, can we reasonably expect professional martyrdom, or to expose yourself or your family to the threat of harm from essentially vigilantes in the community? These are the kinds of questions that sort of underlie accountability. In the Flint case, there were no threats to personal safety, but as we'll see, the officials who made, in retrospect, poor judgments were subjected and are subject to criminal and civil liability. So risking your professional career in the name of public health has some implications for legal preparedness. How can the law define and operationalize a duty if one is imposed? How will law protect the individual who speaks out? If not, what legal changes, if not being, if there's no current protection for an official who speaks out, what legal changes are needed? And is it realistic for officials to expect legal protection? Then in the second presentation, we're going to focus more on even if we have public health heroes, there needs to be accountability. So how do we think about the accountability mechanisms? So as I said at the top, we know that public health decision-making is difficult and complex under the best of circumstances. Both the Flint water crisis and COVID-19 are far from the best of circumstances, and that's a grotesque understatement. Some mistakes in judgment and policy implementation are inevitable. We're not perfect. If you take a case like Flint, did we, as public health practitioners, know enough about the switch from the Detroit River to the Flint River to sound the alarm? I think so. Did we know enough about the Legionella outbreak to notify the public? Maybe. In retrospect, both are mistakes in judgment. How should accountability be imposed? So when sound policy turns out, in retrospect, or frankly, prospectively, to be harmful or wrong. Here, our thinking as a group is that acknowledging fallibility should not inherently lead to culpability, or at least not necessarily criminal culpability, or perhaps personal culpability, but that's a difficult question. So what we want to present is what some of the accountability measures might be. And here we're using the two examples that I've been discussing, where the Flint water crisis led to the tragic harms from lead in the water, failure to notify the public, ignore the potential harms from Legionella, and we have some accountability in the sense of criminal prosecutions, liability litigation against the state. Are there adequate non-legal accountability measures? Censure, termination, changing guidelines, reinforcing the need to notify the public, setting out criteria. So we have to think about a dual set of accountability measures. Some decidedly legal criminal prosecution, liability litigation, some non-legal but with serious consequences for being wrong. And the nature of the talk will be around what's the appropriate level of responsibility for what happened, and how do we determine the criteria, the relevant factors for holding public health officials accountable when they get it wrong. And the third presentation is sort of a mix and plays off both of the first two, titled Beyond the Public Health Code. As you know, most state public health codes provide a broad grant of authority and that public health officials can rely on to justify their interventions. But the codes are not self-executing and offer little operational guidance. In fact, most of them are fairly aspirational in terms of the broad language of the duty to protect the public's health. Thus, public health officials have considerable discretion to act. So most of the time, we're not talking about ministerial duties that an official ignores. Rather, the issue is when using one's discretion, what is the appropriate level of accountability when one gets it wrong? The reality, the overriding reality for all of our talks, all three of them, is that we function within a political system. Sometimes the code is insufficient. The health officer must decide when to go beyond the code. That's sort of the sounding the alarm issue. even if doing so is politically risky. And the two examples that we'll be discussing, I think, demonstrate that. And I think we can say that if we're looking at the Flint water crisis in isolation, there was a failure to use the bully pulpit without getting into all of the nuance of that. The health officer should have had sufficient knowledge of the harms of potential harms of lead in the water to issue strong condemnation of switching the water from Detroit River to Flint, but failed to intervene when it might have, and I want to emphasize the might have influenced and shaped the political environment. In that case, I believe the health officer should have gone beyond the public health code. But COVID-19 is very different, given the intense political and community resistance, and as I said before, the threats to health and safety. It's really hard to expect public health officials to go beyond the public health code, to sound the alarm, unless they were ready to resign. And as it happened, too many were fired in any event for being outspoken. And I admire their courage. So in sum, the health officer's primary obligation is to serve the community, but we need to develop appropriate accountability measures when decisions cause harm, either as in most cases, unintentionally or without adequate attention to the potential harm. But being a public health hero is difficult in the best of circumstances. COVID-19 made it dangerous. And I'll pass it over to Jen.
Hi, everyone. Thanks so much, Peter. And thanks again to all of our attendees for joining us today. My name is Jen Pyatt. I'm a senior attorney with the Network's Western Region office, and I'm a research scholar at Arizona State University's Sandra Day O'Connor College of Law. Now, today I'll be providing a brief introduction to a session that I'll be delivering with my colleagues, Professor James G. Hodge Jr. and Dr. Dan Hansling during our upcoming conference. We plan to discuss revisiting crisis standards of care, or CSC, given what we've learned during the COVID-19 pandemic. Now, this slide presents a brief highlights of our planned September discussion. We intend to assess the trigger points, COVID-19 pandemic circumstances leading to CSC implementation, also the evolution of CSC across COVID-19, some of the important legal tripping points that we've seen play out, and we'll end by discussing what the future of CSC resource allocation and decision-making might look like post-COVID. To set the stage, I first want to come back to the hard data. As of July 27th, 2021, there were well over 194 million confirmed COVID-19 cases, and 34.4 million of those were in the United States alone. That's about 18%. Over 610,000 of the 4.1 million global COVID-19 deaths occurred in the United States. And these numbers demonstrate how hard the US was hit by the COVID-19 pandemic as healthcare workers across the nation shifted to CSC. And with the highly contagious Delta variant circulating across the nation, case numbers are spiking once again in certain locations. What is CSC? The Institute of Medicine, which is now the National Academy of Medicine, first conceptualized crisis standards of care in 2009. They updated it in 2012, and they updated it once again in 2019 in November, just prior to the inception of the COVID-19 pandemic. Because CSC conceptualizes a substantial change in usual healthcare operations and the level of care due to a pervasive or catastrophic disaster. Essentially, when a disaster or a catastrophic event has endured for such a period of time, that shortages and patient surges can't simply be addressed by relocation or stopgap measures, that's when difficult allocation decisions have to be made. And that's when healthcare workers find themselves operating under crisis standards of care. Now, under this framework, healthcare workers have to shift from normal or conventional standards of healthcare, which centers on the individual patient and involves providing care as normal. And they shift along the continuum of care and into crisis standards of care, which is population focused rather than individual focused, and involves saving the most lives as possible through extraordinarily difficult allocation and treatment decisions. Now, in anticipation of our full session in September, I'll reserve a more robust discussion of where IOM and the National Academy of Medicine started with CSC and where we are now, along with projections of where we might be going. But briefly here, I do want to suggest that lessons learned during the COVID-19 pandemic have been profound, have shed light on several legal, policy, and ethical tripping points that accompany the implementation of crisis standards of care. And these lessons are certain to steer conceptions of CSC in new directions. In May 2021, the National Academy of Medicine issued a call to action, explaining that the best time to address crisis standards of care issues is now, after witnessing some of these emerging issues throughout prolonged states of emergency in 2020 and 2021. And I'll briefly start to discuss a few of those tripping points now. So first, of paramount importance during an emergency is the status of emergency declarations at all levels of government. This is because the formal invocation of state-based crisis standard of care plans may depend on state declarations of emergency. If emergency declarations are no longer in effect, and that's particularly relevant now, as more than 20 states have already revoked their states of emergency in recent weeks, hospitals may not be operating under formal state-based invocations of CSC plans. And these plans are intended to avoid difficult resource allocation decisions being made at the bedside by setting out a framework for healthcare workers to apply when it is necessary to triage. Therefore, the importance of these emergency declarations and those formal CSC invocations can't go understated. Now, another legal tripping point that quickly gained traction during the COVID-19 pandemic is the availability of healthcare workers to provide needed care during surges. During the pandemic, states often via emergency orders have waived certain healthcare worker licensing requirements, often enabling retired healthcare workers or healthcare workers with recently lapsed licenses to return and provide care during the public health emergency. States also granted temporary licensure reciprocity to healthcare workers licensed in other states to come in and meet high demand, and often turned to emergency scope of practice expansions to enable licensees to provide care they normally would not be able to provide due to state limitations. We saw this exemplified early on in the pandemic as attempts to increase vaccination led to many states enabling pharmacists to vaccinate individuals, which previously was not within certain states' scope of practice for pharmacists. Now, this patchwork of separate state actions and of state laws enabling those actions produces a very complicated web of licensure exceptions. But healthcare workers are sorely needed under crisis standards, and these kinds of emergency actions can help avoid healthcare worker shortages. Now, the third tripping point that I'd like to discuss is discrimination in CSC decision-making. Over the course of the COVID-19 pandemic, the U.S. Department of Health and Human Services Office for Civil Rights issued several guidance documents and settlement documents relating to state CSC plans to address alleged age-based and disability-based discrimination in those plans. The settlement documents are available on OCR's website, but to be brief here, OCR explained that allocating resources on the basis of age or on the basis of disability is in violation of civil rights laws and should not be included in state-based CSC plans. Now, OCR explained sort of a best practices approach, that decisions should be made based on individualized assessments of each patient using the best medical evidence available concerning the likelihood of death prior to or immediately after hospital discharge. This last part is important, as decisions made based on long-term survival can automatically implicate age-based and disability-based judgments. But these concerns are not the only discrimination-based concerns that arose during the COVID-19 pandemic. Others, including whether or not to continue utilizing the sequential organ failure assessment, or SOFA score, for provision of care, may be subject to reconsideration due to information learned during the COVID-19 pandemic. Research has recently emerged indicating that SOFA scores may overestimate mortality of Black patients as compared with white patients, and importantly, these scores have been used to make resource allocation decisions, thus potentially under-prioritizing Black patients for life-saving interventions. The changes may afford opportunities to devise more equitable solutions in future emergencies. Now, last but certainly not least, a fundamental consideration for healthcare workers during implementation of CSC is the specter of potential liability for actions taken during emergencies. There is a patchwork of state and federal laws, along with professional policies and agreements, which provide immunity from liability for healthcare workers in certain situations. Some of these protections may only be invoked during emergencies, such as liability protections provided by the Federal Public Readiness and Emergency Preparedness Act, or PrEP Act, further highlighting the importance of those continuing emergency declarations. Now, understanding the umbrella of protections available and prioritizing these protections to ensure that healthcare workers remain willing to provide care in crisis are of utmost importance during CSC. Now, I will stop there for this brief introduction to our full-length session in September, but I would like to state before concluding that our hope in September is to illuminate these issues and other additional issues, and to discuss what the future of CSC decision-making might look like considering post-COVID-19 reforms. So thanks everyone so much for listening. I look forward to hearing from you in the question and answer session, and I will pass it over to April.
Thank you so much, Jen. So I'll be talking today about my panel, which is on building racial equity and community into suicide prevention and mental health promotion. Before I give you a sneak peek into some of the issues that I'll be talking about, I just wanted to take a second to acknowledge my co-presenters who I'm really looking forward to hearing from. Christina McCoy from mHealth Fairview, who will be presenting on a community approach to mental health, fostering a sense of belonging and inclusion along the way. And Tyler Dougherty from the National Indian Health Board, who will be presenting on equitable suicide prevention in American Indian and Alaska Native communities. And I will be presenting on suicide prevention, achieving racial health equity by limiting police intervention. So in order to understand why limiting police intervention is a key component to achieving racial health equity, it's important to understand the key issues that operate at the intersection of suicide prevention and race. So the first issue is the issue of racial health equity. As we've seen over the past year or so, individuals have become increasingly motivated to promoting racial health equity. And several jurisdictions have issued declarations of racism as a public health crisis or emergency. And a lot of those declarations make commitments to ending systemic or structural racism, which generally refers to laws, policies, and practices that have a negative, disparate impact on people of color. And a lot of the declarations have also made commitments to listening to communities of color. And an important partner of listening is actually incorporating the perspectives of communities of color. And there's no doubt that police reform has been a top agenda on that end. Another issue that's operative is the issue of at-risk populations when it comes to suicide. So Native Americans and Alaska Native individuals have high rates of suicide. Another population that's at risk is LGBTQ individuals. And even there, we see racial disparities. So the Trevor Project recently did a national survey on LGBTQ mental health. And they found that 12% of white youth and Asian and Pacific Islander youth had reported that they had attempted suicide in compared to 31% of Native American and Indigenous youth, 21% of Black youth, 21% of youth that are more than one race, and 18% of Latinx youth. Recently, a report came out highlighting the troubling figures with respect to Black youth suicide. And in that report, they highlighted a study that found that although Black youth generally tend to have lower rates of suicide overall relative to other groups, Black children ages 5 to 12 were 2 times more likely to die by suicide compared to white children of the same age. Another factor that's operative is the COVID-19 pandemic and its impacts on mental health and suicide rates. So we've seen survey after survey showing that Black and Hispanic people are reporting higher rates of depression and anxiety. And the CDC has also done surveys during the pandemic, showing, for example, that Black and Hispanic people reported at higher rates seriously considering suicide in the last 30 days. Now, the early data suggests that suicide rates as a whole are starting to decline, but this overall picture doesn't tell the whole story. So in some area, suicide rates for people of color appear to be on the rise. So for example, in Connecticut, during a period of stay-at-home orders, suicide rates declined for white people, but increased for people of color. In Cook County, Illinois, the suicide rate for Black people was 97 Black people in 2020, the highest number in 10 years. But at the same time, the number of white people committing suicide trended down and reached a near decade low. So we're starting to see racial disparities pop up. Another issue is the issue of disproportionate use of force. Everyone agrees that we need more data, and there's not a lot of data. But the data that we do have and the studies that are conducted consistently show that police use force, including killings, against Black and Hispanic and Native American people at much higher rates. So for example, the research collaborative Mapping Police Violence concluded that in 2020, Black and Hispanic people represented almost half of police killings, a number that is much higher than their total representation in the population as a whole. And finally, the other issue that's operative is over-reliance on policing to respond to people in crisis. And I think most would agree that this type of system is designed by default and not something that was intentionally designed. Now, it's not all bad news. There's some really great news, actually, which is that the federal government has required the implementation of 988, the 3-digit dialing code that will be in effect in July 2020, that people can dial to access the National Suicide Prevention Lifeline and the Veteran Crisis Line. And so 988, like 911, is really positive in that it's meant to be an easy number to remember when people are in crisis or when their family member or loved one is in crisis. And most importantly, it's an alternative to calling 911. So getting out of that reliance on police model and shifting to getting people connected with trained professionals. There's a lot of good stuff there, but what I'm going to focus on is the fact that it authorizes fees authorizes governments to charge fees to provide 988 services, including for routing calls and, importantly, for providing acute mental health crisis outreach and stabilization services. Specifically, for example, mobile crisis response, which is what I will wrap up with. Really quickly, though, I just wanted to highlight some of the general features of state legislation, state 988 legislation that's been signed into law and that's also pending. So not all of these bills have passed, but they all share, like a lot of them share the same basic framework, such as implementing the surcharge. And a lot of them are starting to envision what these mobile crisis response teams look like. And we see in some of this legislation that the legislation raises equity concerns that I just discussed. So a concern with high rates of suicide, disparities, a desire to reduce reliance on police and unnecessary arrests, a concern with providing equitable access to services, and to providing culturally competent care. So what I've talked about so far is, this problem of, we have this dynamic of increasing need for people of color for suicide prevention services, and then we have those populations that already had a high need for this, coupled with the issue of disparate use of force by police officers. So what is the problem that I'm highlighting here? The problem is that too little attention, under the current system, too little attention has been paid to racial health equity. It's not been a priority. Why is it a problem? Well, as I just mentioned, we have this need for crisis intervention balanced against disproportionate use of force in a system that relies heavily on policing to respond to people in crisis. Well, what is the solution? One of the solutions is 988. And one of the ideas behind 988 is to reduce reliance on police and get people to train professionals. So don't send the police, especially when they're not needed. And so what I have highlighted here is two models of mobile crisis response teams in Nevada and Massachusetts. So Nevada has actually passed 988 legislation, which doesn't establish a mobile crisis response teams, but it does encourage the establishment of mobile crisis response teams. And it sets the standards for who can be on those teams. So you'll see the first two models are either jurisdiction-based or a team established by EMS that has people professionally qualified in the field of behavioral health and peer recovery support services. And so I think that aligns with the goals of 988. However, the third model that they've set forth would be one that is established by law enforcement agencies. And although it does have qualified professionals and peer support, a law enforcement officer would automatically be placed on that team. I think that this kind of model fails to take into account racial health equity. I think it runs counter to some of the goals of 988, and it's not needed. Compare this with the Massachusetts model, which is just it's proposed legislation, so it hasn't passed and it could change, which envisions mobile behavioral health crisis responders. Now you'll see that the three teams that they envision are largely contained professional mental health providers, peer support. But the proposed legislation has a really important piece that I wanted to highlight, and because it sets the standard for when police officers should be involved. And so it says, mobile behavioral health crisis responders shall collaborate with law enforcement agencies and include police as co-responders in behavioral health teams only as needed to respond in high-risk situations that cannot be managed without the assistance of law enforcement personnel. So I think that this kind of model comports more with racial health equity and sets a high standard to say, this is when we're going to call the police officers. They're not automatically going to be part of the team. So what I'm not saying is that we should never have, that there's no role for law enforcement that they should never be involved. But what I am saying is that there's an opportunity to take police officers out of your starting five. So for those of you who watch the NBA, right? So right now, when people call 911 or in the Nevada model, they would be part of the starting five. But what the Massachusetts standard does is put them on the bench. And I think that is a much stronger model, because you have to think of law enforcement as your bench specialists, right? You're only going to call them out in high-risk situations when they're specifically needed, and not make them a core part of that crisis response. So I think that given all the considerations with disparate use of force, the growing need for crisis intervention, and people anticipate that there's going to be a huge uptake once 988 is fully implemented. The Massachusetts model is a much better model, and I think it shows in practical terms how you can start to build racial health equity into law and policy reforms when it comes to suicide prevention. Thank you, and I will pass it on to Betsy.
Thank you, Peter and Jen and April, for those great summaries of your presentation panels at the upcoming conference. Really appreciated. So I am just going to encourage attendees again to please be sure to enter your questions that you may have for any of the presenters in the Q&A panel on the and select all panelists and type your question and then click send. And I can start going through some of those questions and relaying them to the presenters. So to start off, Jen, I just had a question here for you about the specifics of liability coverage under the PrEP Act. So what liability coverage does the PrEP Act provide for healthcare workers during emergencies?
Thanks, Betsy. That's a great question, and it's a broad question, but I will distill it as best I can here briefly. So persons involved in the administration, the use, the manufacture of countermeasures against COVID-19, this can include COVID-19 vaccines or treatments as defined in the specific PrEP Act declaration documents. Those people are protected from immunity for negligent actions involving the administration, use, development, manufacture of those countermeasures. They are not immune from willful conduct. And the PrEP Act, importantly, within that definition, does not extend to all conduct undertaken during the public health emergency, but only to conduct that actually involves these countermeasures. And this starts to exemplify kind of why it's important for healthcare workers to understand all of the liability protections available or in operation during an emergency. For example, if you contrast this with the CARES Act, which was passed by Congress last year, the CARES Act protects interstate volunteer healthcare workers responding to the COVID public health emergency. So there's a web of interconnected liability protections from all these kinds of different sources that all may provide protection for specific instances.
April, there's a question for you about what are some of the other levers that could be pulled to reduce the reliance on police in many of these situations?
Yeah, I think that it's important when we, as I said, if we're going to be issuing these declarations of racism as a public health crisis and listening to community voice, there's no doubt that policing is a top priority. Police reform is a top priority for communities of color. So I think that when it comes to suicide prevention, we have to look at the various areas in which, whether intentionally designed or by default, that police are involved in that process unnecessarily. So in addition to looking at mobile crisis response units that, that are being envisioned with 988, Another area of interest and something I'll be talking about at the conference is the anonymous school tip lines. So these are tip lines where you can report a threat to, a student safety or to the school. And they were initially implemented in response to mass school shootings. So being able to identify that troubling behavior before such an event happens. But what schools have found, at least the ones that are reporting data, is that actually tips related to threat of suicide, death by suicide, are often among the top 3 tips reported. Also bullying, you have depression and anxiety. And so really these tip lines have been more about protecting student mental health rather than protecting the school against a mass threat. But these tip lines operate in different ways, and some of them connect the anonymous tipsters to trained professionals. Others connect them more to the police and automatically send the tips to the police. And so a police officer might be sent to a student's home for a suicide threat. So that would be like another example of where we could really look at that and think about how are we going to reform this to meet the need that that's actually out there. And then another area is looking at extreme risk protection orders, where you can petition the court to have someone's firearms removed if they're a threat to themselves or others. And again, this has been a great tool for suicide, but looking at, well, who can petition the court? Most states allow police officers to petition the court, but let's expand who can petition to, more family members, mental health providers. We don't need to get the police involved. And then looking at, well, once you say that you get the protective order and someone has to surrender their firearms, oftentimes they have to surrender the firearms to the police, but other states have different models of doing that. So, I just think you really have to look at suicide prevention comprehensively and say, where are the police serving a function, and do we really need to have them there? Or can we provide a more equitable system where people who have negative encounters with the police aren't going to experience that when they're, going through suicide prevention, a system that's designed to promote their mental health and well-being.
Thanks, April. That's really helpful. Peter, we have a question for you about, you mentioned that developing appropriate accountability measures is essential when decisions can cause harm. Do you want to expand on any potential examples that might be useful to consider?
Sure. And in part, this does relate to what Jen was talking about in terms of how we set the legal threshold. So if we make a similar an analogy to crisis standards of care, where, as I understand, Jen, what you're saying, the default option in these acts really is gross negligence. If one is negligent under sort of a failure to meet a community standard, there's no liability in a crisis situation. And what I've argued in other venues is that same standard should be applied when public health officials make an error in judgment. That if it's negligent, maybe there are some internal sanctions. Maybe I should, if I'm the chief health officer of a state or local health department, I can be sanctioned, maybe even terminated. But there should not be broad liability, either to me personally or the state, unless I've met a much higher threshold of recklessness, of gross negligence. But if we look at it from the standpoint of a community, such as the Flint community, that's not going to be very satisfactory after the tragedy that the community has suffered. And what they want is criminal culpability. And they're not going to, but is that an appropriate measure from what we would expect? There are ramifications to holding our public health officials and similar officials criminally liable. And it's hard to balance what the community wants when the harm affects, such as the lead levels in kids that are irreversible, with what we might expect over the long term of how to hold people accountable. So those are some examples. COVID-19 merely exposes all of these tensions. It doesn't resolve them. It doesn't give us a sense of how they can be resolved. And what we're trying to do on this panel is to raise those issues and start the dialogue to determine what are the appropriate accountability measures. How can you balance what the community wants and really needs with what we think the long-term implications would be of imposing criminal liability.
Thanks, Peter. Let's see, we have another question here for Jen. What are some of NASEM's priorities as laid out in the May 2021 call to action?
So I just want to echo Peter's sentiments, because COVID-19 exposed everything, and it brought much more attention to these issues because we saw case on case on case play out in real time. And so what that NASEM call to action in May 2021 did is it viewed some of these issues and it addressed these issues, and it focused on some of the issues that I discussed briefly. But the framing device in the NASEM call to action is to address equity. The vital consideration is what the call to action said, and this is demonstrated by COVID-19's absolutely disproportionate impact on marginalized populations. The call to action also prioritizes things like addressing liability and addressing emergency declarations. So ensuring that strategies are in place to make sure that healthcare workers and local officials have kind of agreed upon thresholds for what a crisis actually means and when they are in crisis. Ensuring that healthcare workers understand those liability protections that are available, developing policies to support common allocation decisions that repeat over and over and over so that we don't have unneeded pressure on providers at the bedside to be making these really, really difficult ad hoc decisions if we can avoid it. And also ensuring that there are enough staff through surge staffing plans, through increased education about surge plans, increased education about what a crisis means. So a lot of these issues that I previously discussed are present and are call to action, seeking to be addressed by the National Academies of Medicine because of their exposure during the COVID-19 pandemic.
Can I add something to that? In a sense, this isn't a new problem or issue. For example, in a set of interviews that my colleagues and I conducted around routine and emergency public health preparedness several years ago, one respondent, a first responder from the law enforcement side, said, in an accident, I'll have 30 to 45 seconds in a mass accident to identify people who can be saved. In a major accident, a bioterrorism outbreak, a pandemic, I'll have 3 to 5 seconds to make that decision. How can we impose liability on that person who simply must make a split decision without the opportunity to contemplate whether person A or person B can be saved? So again, I agree with Jim's take that it's not necessarily a new problem.
No, absolutely not. I agree, Peter. I think it's certainly not a new problem. It's gained, some of these issues have gained quite a bit more visibility, I think, during the COVID-19 pandemic because of the number of cases that we've seen.
Agreed.
Jen and Peter. April, there is another question for you here about the Nevada Police Mobile Crisis Model that you mentioned in your presentation. Is one of the benefits of that model is that it could train police on how to be better co-responders?
Yeah, I mean that's certainly an argument that you could make, is that by incorporating police into this model, they're getting the appropriate training. On the other hand, if it's not necessary for police to respond, if you don't need the skill set that police officers have, from an equity perspective, and particularly a racial health equity perspective, why bring them to the scene, right? Because the numbers that we show are just again and again disparate use of force. And I know that a lot of jurisdictions do use a co-responder model where police officers are trained to show up with mental health professionals, even outside of the 988 context. And while there's evidence that police officers' perception of use of force, they perceive themselves to be using less force, there's not really evidence that they actually do use less force. And so there's not really much support to say that, although they might perceive themselves to be less forceful, it's still up for question whether they actually are using less force. And, there's also evidence out there for a lot of communities of color, especially Black and Hispanic communities, that police encounters in and of themselves can be very negative and adverse. So why use them in a system like suicide prevention when the goal is to promote people's mental health and well-being rather than inflicting another trauma? So that's why I think that the Massachusetts standard saying, look, when there's a high-risk situation where you need law enforcement, then yes, they should be trained and they should be there. But otherwise, they're not needed.
Thanks, April. So it looks like we're nearing the end of our time, but I just have one more question that came in for Peter about legal standards for accountability and whether you see changes to those standards after disasters or times when political health or public health measures are the target of political attacks.
The answer is both yes and no. And it's a longer conversation, pardon me, because there's this tendency to react in the moment. But there's little evidence of change over time in the legal standard and how it operates. I mean, I think that's sort of what Ken and I have been sort of talking about, and that you have the sense that we still haven't clearly in the law defined appropriate culpability. And it will change sometimes in the short term, but not necessarily in the long term. It won't necessarily be, these changes won't necessarily be adopted across states. So you may, and one final point, it's as much a political decision as it is a legal one. And I want to reiterate a point I made during my presentation, that we always have to keep in mind the political context in which public health is practiced. But it's an important question. I'd like to pursue it further at some point.
Thank you, Peter. And we have only about 1 minute left. Does anyone want to just have a final thought that they'd like to share with the audience? If not, I think we can wrap up. Thank you so much for providing this insight, and I am really looking forward to learning more about all of these topics during the conference. Much appreciated.
Thanks very much.
Bye-bye.
Bye.